Okay. A few years ago, when Dr. John Fish visited my university hospital, he was surprised that we still had so many patients being treated for Pott's disease. He said, "Is Pott's disease still a big thing in your country?" Of course, in almost all third world countries, tuberculous spondylitis is a very common thing. And I think it's also very common in sub-Saharan regions and the rest of Asia, as I will show to you in a short while. So when we talk about controversies in the role of spinal orthotics in spinal diseases, probably one of the most controversial will be the efficacy or the utilization of spinal orthotics with regards to spinal infection. And it's just but fitting that this is a new chapter in any other book that you might find about spinal orthosis in the use of spinal infection, because it doesn't exist at all in any other book. Imagine, for example, if you create an atlas and you miss on just one country. What would be the effect of missing out on one country in one globe or one atlas for the future generations? So probably it's just but fitting that we will have a new chapter in a book on spinal orthosis with regards to the utilization of these devices for spinal infection. Now, the spine is a very long segment composed of the spinal segment, okay, which constitutes the vertebra, the ligaments, the capsules, the muscles that connect it, and the very important intervertebral disc around it. And we know for a fact that the spine exists to protect one very special tissue, and that's the spinal cord within that goes in the spinal canal. Now, the functional unit can be affected by so many things. It can be affected by trauma, it can be affected by infection, it can be affected by congenital deformities, by neoplasms, and even by malignancies or degenerative processes. Okay. Now, all of these problems, trauma, infection, congenital problems, neoplasm or malignancies, and degeneration, can bring about problems that deal with pain, instability of the spine, deformity of the spine, and then, if worse comes to worse, and all of these are not properly dealt with, the patient develops neurologic deficit because the problem has now invaded the spinal canal. Now, when we talk about all of this problem, this chapter is now concentrating on the problem of infection and how it affects the spinal unit. Specifically, you can find out that there are so many disease entities that will affect the spine, okay? And in this new book on the spinal orthosis, the topic on spinal infection is properly dealt with. Infection can affect any part of the spine, from the cervical area, thoracic, to the lumbar area. And as you can find, it can be called by different names. It can be called infectious spondylitis. It can be referred to as vertebral osteomyelitis. It can also be called spondylodiscitis, meningitis, and myelitis. Very often, these terms are interchangeably used loosely, but as you'll find in this book, they have specific entities whereby you have to use these terminologies. Spine infection, or spinal spondylitis, is a very rare condition, and it constitutes only 1 to 7% of all bone infections. However, as you may see, when you have spinal infection, it will not affect just the bone the way we always perceive it to be. It can be an infection of the subcutaneous area. It can be an infection of the posterior elements. It can be an infection of the vertebra by itself. It can affect only the disc and the vertebra altogether. And if worse comes to worse and all of this infection is not properly dealt with, it can now invade the canal where you have your spinal cord, and you might develop meningeal irritation causing meningitis and myelitis, which is an infection of the spinal nerve roots. Now, as the case may be, what I mentioned a while ago, that it's a very rare condition, in actual clinical practice in our hospital, you can see that most of the thoracolumbar problems that we have, trauma, malignancy, congenital deformities, and degeneration, in the middle, you have infection constituting 15% of these problems. This is over the thoracolumbar spine, and if you go over the cervical spine, there's just a bit of difference between trauma and degeneration, but again, in the middle is infection of the spine. So meaning to say that it's not as rare as it could be, that infection of any part of the spine is something that we really have to contend with most of the time. Now, if you look at the map, you can see that countries are categorized as developed, underdeveloped or developing country. And as you can see, the preponderance of what we call developing countries. Over the sub-Saharan area, most of Asia, and in the country that I come from, spinal infection is one problem that we have to contend with. That's why I was very happy when John invited me to write a book on spinal infection, because I know it's a very important topic that has to be dealt with by a lot of practitioners in many other countries. Now, this book classifies infection in either tuberculous or non-tuberculous. When we refer to non-tuberculous one, we refer to bacterial infection, viral infection of the spine, fungal and parasitic infection of the spine. When we refer to the tuberculous problem of the spine, we refer to the old classic name of pus disease, which is a big ailment in most of the countries that I have shown you in the developing countries. Now, it goes without saying that you might surprise you that 90% of all spinal infection is tuberculous in nature, and only 10% are not tuberculous in nature. The problem that we have is that infectious spondylitis is usually considered in most developed countries as a surgical condition. But mind you, WHO and all other countries consider infectious spondylitis as a medical condition, not a surgical condition. It only becomes a surgical problem because of the biggest problem of spinal infection, in that 70% of spinal infection are usually diagnosed very, very late. How is that so? This book shows the pathogenesis of infection with regards to the spine. As you can see, first, when you have an infection of the spine, the root is hematogenous and it goes to the vertebral body. You have a nidus inside the vertebral body that slowly grows, and at that point in time, most of the time, patients only have pain as their chief complaint. Some would not even have fever at all, even if this is infection. Because when you have tuberculosis infection, fever is something that doesn't exist very, very often. Yes, you have general body malaise, you have late afternoon fever, but generally patients are still up to their work. And usually, when they have pain, this will misconstrue as something secondary to hard work, something related to sports, or any other activity that is not of the usual. So patients don't usually consult doctors and they self-medicate. Now, the problem comes now when the nidus of infection becomes bigger. The bone starts to crumble because of the osseous affectation. Pus starts to accumulate, and sometimes they now extrude into the spinal canal. At this point in time, patients have much more pain and they have problems going around. And it goes without saying that it doesn't take long before the infection becomes bigger, now affecting the spinal canal, and subsequently it affects the adjacent structures and thus starts to cause deformity and instability of the spine. It is at this point in time that the book will show you that patients are start coming to doctors, and this is time that they get to be already diagnosed. And when you're diagnosed at this point in time, it's quite very, very late in the disease process, and patients usually have big instabilities of the spine and deformity of the spine that we, orthotists and prosthetists and doctors, should initiate our treatment with. So the book also describes very well the biomechanics of the spine. Traumatically, Denise have divided the spine into 3 columns, the anterior, posterior, and the middle column. And in general, for prosthetists and orthotists, we just have to think that the spine has 2 columns, the anterior column, constituting the vertebra, and the posterior column with all the elements and the muscles behind. Now, it also goes without saying that infection of the spine is something that is very hard to perceive. With very poor imaging techniques, you won't be able to find out if the patient has a problem only in the anterior elements or merely on the posterior elements, or if both elements are affected. So it's very, very important as well that orthotists and prosthetists should discuss things as a teamwork with their physician so that they will have a glimpse from the imaging of the MRIs and the CT scans and also the X-rays where the problem is. Is the infection anteriorly? Is it posteriorly found? Are both anterior and posterior elements affected? Or do you have contiguous affectation of the spine? Or do you have skip infection of the spine? Or do you have atypical infection of the spine? And these are all found in that book. Now, Benzel gave a very graphic description of how you should perceive the destruction of the spine. He divided the spine into 27 cubes, very much like a Rubik's Cube, And he described how, if each of these cubes are destroyed by infection, can cause severe instability of the spine. And in the book, you'll find how the specific cubes of the spine can be affected to give that instability that will cause problems for our patients. When we refer to the regional specification as to where infection might happen, it is going to be very important to find out that most of our infections will be found over the thoracolumbar area and the thoracic area. And this is something that is quite very important because we have to remember that nowadays we have so many spinal orthotics available at hand, and we should be able to use the proper ones for our patients. These are the different braces that we have. These are all properly reviewed in the book, okay? But the problem is, when do we use one and the other? So we gave a very graphic description with the table. On one hand, you have the different levels, occipital atlas. We have C1, C2, CT, C3. We have the cervicothoracic junction. We have the thoracic area, the upper thoracic and middle thoracic area. And then we have the thoracolumbar junction, lumbar and lumbosacral junction. And on the top corner, you'll find infection not involving the osseous structure, followed by the anterior elements being affected only, subsequently the posterior elements being affected only, and then lastly with both anterior and posterior elements affected. So with this table, we were able to categorize what kind of braces we have to use for our patients, and they are also graphically shown as good choices in a graph. This you can find in our new Atlas of Spinal Orthosis. Now, the book also shows very classic or graphic example of how things can be treated with the specific problems. In this example, you have a cervicothoracic you have a occipito-cervical infection at C1, C2 with a skip lesion over C7. And for this patient, it would be nice to use a spinal orthotic using a halo vest device. The book also shows how we can modify this halo vest device, specifically in countries where a halo vest device might be a luxury. Because nowadays, I haven't found most countries using Minerva casts anymore. No? In our country, even in the provinces, we have halo vest devices already. And when these halo vest devices are not available, some of our physicians don't know what to do anymore. And we still teach them that the classic Minerva cast can be still used. Or if you have a halo ring, you can use a halo cast device, and that will be as good as a halo vest device. And that is very well much discussed in this atlas. Now, when we have problems over the thoracic area, it also shows how the classic Milwaukee device can still stand for problems wherein you need to immobilize the cervicothoracic junction in the thoracic area. In this case, we compared the use of a Milwaukee device in a Riser cast. And quite interestingly, you might find out that there are various means by which we can modify our total body jacket and our Riser cast. As you can see here, the traditional body jacket and Riser cast will only have a window over the abdominal area, which will allow us some comfort when we eat. But why do we have to put bigger windows in classic examples like this? It is because in infection, we have a specific problem. In most cases of infection, you have a pocket or a local pus that is found over the thoracic or the lumbar area. And if you have a very tightly or snug fitting total body jacket, the increase in intrathoracic pressure and abdominal pressure might be too much, and it can cause a dissection and the subsequent metastasis of the infection over other areas of the spine or other areas of the body. That is why we provided choices whereby specific problems of increasing intra-abdominal, intrathoracic pressure might be avoided. In this example, we show a classic lumbosacral corset, but mind you, you can find that over the cross-sectional MRI, you have a big pocket of pus over psoas abscess. The book discusses how you can avoid increasing abdominal pressure that might cause the further dissection of the psoas abscess. The book also classically goes back to the use of hip spica. classically, hip spica is being used for children and other related problems for trauma in children. Now, we have gone back to the use of hip spica for problems whereby we want to treat our problems with infection over the lumbosacral area. And we have shown some modification of prefabricated and manually made hip spica procedures. The book also goes back to the biomechanics of the devices that we use. The whole atlas, in every chapter, will discuss the biomechanics of the specific orthotic devices that are being used. And in this chapter, we sort of modified how these specific biomechanics pertain to problems wherein we have increases in intracranial, intrathoracic, and intra-abdominal pressures. Lastly, the book shows why we have to treat patients with infection of the spine. When we have infection of the spine, there will be subsequent collapses over the areas where it's infected, thus causing an alteration into the center and line of gravity. And the natural mechanism of the body is to try to compensate and bring this line of gravity back to where it is. And patients develop a lot of sagittal imbalance. So the book tells us how the musculoskeletal system is affected if the patients are treated late with improper treatment and improper choices of devices. And it gives us a very good glimpse of how patients will have problems with properly treated infection of the spine. Now, the biggest controversy still lies within the book. Are all of this evidence-based? With the amount of literature review that we have done for the book, I think it's up for us to see if really infection of the spine can be treated properly by orthotic devices. Nobody loses anything with the book because it's free. You can download it, no? And it gives us a very good literature review and a very good glimpse of the things that we have to do when we have to treat patients with infection of the spine. Thank you very much.